Hello. Benjamin's going to be here in a few minutes. He's finishing up on some schoolwork that he has to do. He's got a little class he was doing.
Hey.
Here he is.
It's Fat Albert.
Oh my goodness.
Anyway. All right.
Here we are.
Hey, I made it.
Welcome.
So, yeah, it was a interesting Zoom discussion. I was on with my professor and some other students. It's recorded for the class. So it was pretty helpful. It was good stuff.
So we went over like the polls that I had put up for everyone. And some people wanted to know a little bit more about us. Some people wanted to know information about progress notes. And what was the other one? General nursing tips.
Yes.
So I thought we could do kind of some of both each.
Yeah, a little bit of everything.
So maybe we'll start out with a little information about us.
So I'm Benjamin.
I'm Naomi.
And I've been a nurse since 2009.
That's why our name is Benomi. Benjamin and Naomi. It's
Yep.
our names together. In case, and look, I have a t-shirt. In case anybody was wondering where that weird name came from. It came from an 11-year-old boy who, when we were dating, was like, Benjamin and Naomi, that's like Benomi! And we're like, that's amazing.
Yeah. So,
Anyways.
yeah, I've been a nurse since 2009, and I have a wide background in, acute care and, medical telemetry, med surge, neuro, advanced care. I've done clinic work. I've worked in hospice care as a case manager and also doing triage, night shift. So I've done quite a bit of stuff in my time. And currently I'm in school at Herzing University, pursuing my master's degree to be a mental health nurse practitioner. So graduate in a couple of years.
And I've been licensed since 2013.
Mm-hmm. Next month it'll be 10 years.
That's so long. Our cat is joining us. This is Oliver. Say hi. Hi. So yeah, almost 10 years. Before that, I was a STNA or CNA for about 7 years. I've always worked in long-term care with a couple of stints here and there of home health, but for the majority, it's been long-term care until 2022, right? Until last year when I started at a wound care clinic. So I've been doing that for a year and a half or so, and I really like it. Oliver. Hi.
He just wants to be where the action is. Our cat is very jealous of our affections, so he wants attention all the time, unlike most cats. He craves our attention, so
I did also have the opportunity to be in management when I was working in long-term care. I did that for about a year and a half-ish as what's called a unit manager, where I was managing staff and patients over particular units in the facility. And then I was also assistant director of nursing. I only did that for a few months because at that particular location, it was just not a good fit. So we'll leave it at that. But that's about enough about us, I think. Anything else? We have 2 cats. I think that's about it.
Yeah, and we live in Florida, so we love our sunshine and palm trees. So sorry if you guys are somewhere cold. We know fall is getting started and it's getting kind of yucky some places. So we'll send you love and warmth and sunshine wherever you're at.
At least love. Anyways, so maybe we can talk a little bit about some general nursing tips. So one of the things that we have talked about, and we did a short, I think, on it, was administering, for patients in hospice, administering Ativan and morphine.
Yes, and The preferred way to do this is sublingual. What's really neat is that even though Ativan, the hospices are kind of moving away from what they call the Ativan Intensol, which is the liquid concentrated form of Ativan, and they're moving more towards just the tablets, and the tablets themselves are dissolvable sublingually. And so a little tip, for comfort is to you can draw up your morphine, and you could put the Ativan in a little cup, and you can dissolve it with the morphine. You just take the morphine, you squirt it in the cup, and you kind of let that set for a couple minutes, and it'll dissolve, and you can draw them up together in the same syringe. So that's just something that is an option that I've educated family members on doing.
That's nice because you're not adding any extra liquid for the patient to have to swallow or deal with.
Yeah, exactly. And there's even patients that don't think too that morphine is just strictly for end of life, because I've had clients who were using liquid morphine who were going through hundreds of milligrams of that stuff every week, and they were completely with it oriented and ambulatory. Their PPS, or their palliative performance score, was still about a 40, which means that they were functional to some extent but needed a lot of help, between a 40 and a 50. So don't a piece of education possibly for family members, and for other nurses as well, kind of help dispel the rumors that comfort meds are for end of life only, that somebody is imminently dying because they're getting these medications. That's not true. So add that piece of knowledge to your knowledge bank, and share it with your coworkers, and share it with family members as well.
And then to bring progress notes in on that, if you say we're working in long-term care and you have a hospice patient and you administer those medications, you should write a progress note, because you're giving something that's PRN, unless it's routine and scheduled, which is really good as a side note. If you do work in long-term care, it's a really good idea to ask the hospice nurse for routine Ativan and morphine. It doesn't even matter the frequency, like every 6 hours, something, because it's really easy to just fall through the cracks, and they are likely to not get it if it's not routine. So it's just a good idea to make sure the patient is comfortable. But one thing you could say is, like one indicator of pain is increased respirations. And so what you can do is say, patient noted to have respirations of 28 and facial grimacing, PRN, morphine, and Ativan administered. Done. That's it. It doesn't have to be some huge, long, drawn-out note. But then say, 20, 30 minutes later, you do want to try to write a progress note, follow-up note that says PRN administration of Ativan and morphine effective. Respirations are now 18 a minute, or whatever. That way you're showing that it was effective and there was a reason, to give it.
So do we want to talk a little bit about hospice, or do we want to just talk more about the progress note stuff?
I don't know.
Well, we got a little bit of time, don't we? So, so, when it comes to, to the pain medication, if you're working in a long-term care facility and your patient is getting started on these medications, you might encounter some resistance from family members, because, as I mentioned, they might believe, thank you for all of our people that have joined us. So, hello. Hi, Dr. Schmookler. So glad you're supporting us. So, too bad I don't get to see you in the clinic anymore, but it's still good to see you here. But, so you might encounter some pushback from family members who are adamant that their loved one not receive comfort medications. And so something I like to let them know is that this process is going to happen. it's inevitable. The dying process is already, the gears are already in motion. You can't control the outcome, but you can control
The
how
journey.
the journey. Yeah, exactly. That's a good way of putting it. You can't control the destination, but you can control the journey, which is the experience on the way there. And so that's oftentimes, why, in fact, hospice nurses do call it a journey when they enter hospice. It's a privilege, we would say to their loved ones, it's been a privilege to be with them on this journey. And so let them know that the medication is not going to hasten death. And actually, in fact, patients tend to die sooner if their pain and symptoms are inadequately treated. So keep that in mind. That we use morphine a lot for our heart failure patients. They have a New York Heart Class Association score of 4, which is debilitating heart symptoms, dyspnea at rest, and requiring supplemental oxygen. If you have a heart failure patient, let the family know, hey, this morphine is good. It's helping to open up their airways. It's helping to relax things. It's helping them to breathe. And we don't want them to suffer. So definitely take that route. Let them know that these medications are going to help them not to suffer. Um, so there's other medications in the hospice arsenal, but those are two of the more common ones. I feel like we should do a whole other live thing about hospice. That might be interesting down the road, because I have a lot of experience in that field.
We both have some passion with that.
Yeah, you know.
So maybe some other general nursing tips too. One I think of for dementia patients is, and I'm very passionate about this. Make sure your dementia patients are medicated for pain, because so many times dementia patients are agitated, they're acting out, they're getting combative because they're in pain and they can't express it and they're not being treated for it. All it takes is some extra strength Tylenol a couple times a day. Make sure your dementia patients are medicated for their pain. Like, I'm only in my 30s and I'm sore when I wake up. So imagine how sore an 80-year-old is going to be when they get out of bed and they can't even tell you that they're hurting. So medicating for pain in dementia patients really decreases behaviors, it decreases falls, and you're making them feel better. It's increasing their quality of life. So there's a tip for you there for dementia patients.
And
Also,
that applies to acute care as well. That applies to working in the hospital. Oftentimes, we think, oh, they have a UTI, or, oh, they got something going on, they're just crazy or whatever. But maybe they're in pain, maybe we don't do as good a job, as healthcare professionals in acute care, recognizing symptoms of pain, nonverbal, behaviors of pain. So, we need to, keep an eye on that, and, you know, um, do our best to treat patients there. So, we had somebody else join. Thank you.
Hey, Christian.
All right.
He knows all about dementia patients. What's another thing? Let's see.
So, do we want to talk
So,
about...
like, when you think of people acting out, for instance, if they're doing personal care, you're rotating them in the bed and they're lashing out, maybe it's because it hurts. Like, you're moving them in the bed. It might just be hurting them.
That very well could be. I'll speak to this point. I had a very rough night, a dumpster fire of a night on Friday. Got floated to the neuro unit, and one of my patients came in with altered mental status. He was in a posy vest and bilateral wrist restraints. Dude was just out of it.
Can't do that in a nursing home, by the way.
No, which is, kind of cool in the hospital, because you can tie him down. So anyway, that comes with pros and cons. The con is charting, and there's a lot of liability, and you might really, really tick off a family member, which also happened to another patient who had to put in restraints. So I had 2 patients in restraints. Oh, God. Anyway, point is, I noticed that in the ER, they gave the man a pretty good loading dose of morphine. So part of his agitation actually could have been related to pain. Then we medicated him with some Ativan. He took a ride on the van, as they say, and he chilled, a lot of the night. And
And
so
then,
can I speak about restraint usage real
yeah,
quick?
sure.
So nurses, I know if you work in a hospital, you're tempted maybe to try to keep on restraints as long as possible, but don't do that. This patient, he was very altered at the beginning of the shift. Speech was slurred. He couldn't even communicate. But by the end of the shift, he was coming around. He was more oriented. He verbalized understanding of the discontinuation criteria, and I let the restraints go. So he was in restraints for about a good 10 hours and took the restraints off. You might be tempted to say, oh, well, I'll leave him on until, next shift just in case. No, if they don't meet the criteria for him anymore, do the right thing. Take them off. We know, we joke, about, oh, yeah, let's tie him down, blah, 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 but in all seriousness, patients have a right to be free of restraints.
That's a
Sometimes,
nursing home resident right. Good job.
yes, they have a right to be free of restraints. Sometimes in the hospital, though, they revoke that right. So, but you have to give them their rights back as soon as they're, oriented and with it and no longer pose a danger to themselves.
Yeah.
Because this guy was a super huge fall risk, and he would have split himself in half if he had gotten out of bed. So, well, whatever.
Anyways, another good tip for like giving med pass in a nursing home, especially if you work like 3 to 11s or are going to be giving a 9 p.m. med pass, is to like do it in the certain order. So you give your like alert and oriented patients their meds first, and any IVs, and then like anybody who usually takes a pain pill, you want to get them going, because you're probably going to run late on your med pass. I mean, that's just how it is. And what you want to do is save the nicest people for last, like especially if they're confused. The nice little confused people that are just going to wake up, they don't realize that it's 11 o'clock because you're really late or something, and they take their medicine and they go back to sleep. Not some alert and oriented person that starts cussing you out because you woke them up to give them their meds. So,
here's your trazodone. Knock, knock. It's 11 o'clock.
Just a little tidbit that helped me when I was getting yelled at by alert and oriented patients. So that's when I started doing that.
Sure, and in the hospital setting and in terms of medications, one of the tips I mentioned, in our TikTok, videos, if you haven't found our TikTok page, make your way over there. So, Nursing with Benomi. So anyway, in terms of stabilization, in terms of prioritization, I mean, of course, choose your sickest patient first. Choose your sickest patient first. And last week, I had 6 patients. 3 of them were Spanish speaking only. So.
But she doesn't speak Spanish.
No, I just know un poco, just a little bit. I know how to say "Mi llamo Benjamin, soy enfermero para noche." So, I'm your nurse for tonight. That's it. I'll see you later. Anyway, so if your patients that speak English as a second language, or otherwise your non-English speaking patients, if they're stable, they are going to require more time. So they will often need to use a translator service at your facility, whether it's a translator phone or if it's an active translator app using an iPad or another tablet or another system, whatever it is. We have a pretty good translating system at our hospital over here in Florida, so it works pretty good. Otherwise, in other words, you can kind of follow Naomi's tips. They apply really well for nursing home and acute care. You know, that pecking order there. You know, your you know order prioritization. It's good to keep in mind.
Another quick tip for I speak for long-term care. I've never worked in the hospital and have zero desire to ever do that. So what I know is long-term care and some wound care stuff. So when you're like planning out your shift for the day, which I suggest you go through, see who all your diabetics are, see who is a DNR, or in some cases who is a full code, whichever is more or less. Anyways, know what everybody's code status is.
Yes, very critical.
See who has appointments for the day, see who has IVs, check to see who needs like a PRN stool softener or something if they're haven't had a bowel movement in a couple days. And then you write all this stuff down, which I do have a shift planner I'll show you, but it's going to be backwards, but you can download it for free, where you can write out everything. And that way you just have everything on one sheet of paper, and you know who, like, what treatments you have, and blood sugars, and who has medication given at some random time, like 2 p.m. outside of the normal med pass times. And that's very helpful as well to know, just have it in mind how your shift is going to go. If you can do that when you start your shift, is really good.
Yeah.
So
That's good stuff. Stay tuned on on YouTube and on Instagram and TikTok. I want to share a really personal, inspirational story about hospice care that will warm your heart. So stay tuned for that. That'll be coming up in a little bit.
not like right now.
Not like right now.
A few days.
Yeah, a few days down the road, because I'm working the next couple of nights after tonight, and I got projects and stuff, so I'm gonna be pretty busy. So, but we'll make time for it.
I think that's about it for tonight. You think? Yeah.
Yeah, and Dr. Schmookler, if you're still there, message me and let me know when you're gonna be in the hospital. So you'll have to stay late one night so we can chat. So.
Well, thanks everyone for joining, and if you haven't subscribed to us on YouTube, go ahead, and if you're on YouTube and you haven't subscribed to us on Instagram, go ahead. Instagram is a great platform for us to be able to talk and DM and everything a lot easier, and I get on there and do stories and stuff, so you're missing out if you're not on Instagram, just a little bit.
And we're still getting our feet wet with TikTok, because we're millennials and we're not Gen Z, and we don't know how to do all the crazy stuff, so we're trying.
Anyways.
We're trying. I'm, an
I
aging
had to,
millennial.
I had to Google how to connect my Instagram account to YouTube, to Facebook. So, anyways. Well, thank you guys for watching. I hope you all have a wonderful night.
Mwah.